So good morning everyone, welcome to the Aishala. So the first presentation is on ocular anatomy. So this was basically originally a 45 minutes presentation on A to Z of ocular anatomy, but for the time constraint and all, we have reduced it to 30 minutes. So naturally I have to rush through my slides. So feel free, you have any question after the talk. Uh, so this talk is basically dedicated to my anatomy teacher, the late Navaran Purkayastha and late Avinash Chandra Pal. They taught us the anatomy in our undergraduate days. So this is just a quick revision course of ocular anatomy. I'm sure none of you are expecting a 360-degree coverage of ocular anatomy in a particular session or particular talk. So we'll be discussing 26 ocular anatomy mixed with some fun and quiz. And you have to remember that the speaker here is not an ocular anatomist or a professional graphic designer. So as a clinician, I have tried my level best to highlight some of the very important aspects of these anatomical facts with my limited skills in knowledge and drawing. And also there is a bias in the selection of this topic, like there are topics from oculoplasty and strabismus which has come very little in this talk, and all these diagrams are actually basically drawn by me. So don't expect that it will be a very hi-fi or 3D kind of diagram here. So let's start with angle of anterior chamber. Now, when we talk about angle of anterior chamber, let's see how it forms. So what happens in this just adjacent to the limbus, there is an indentation or groove on the inner surface of the limbus that is called scleral sulcus. Okay. Now the scleral sulcus has a sharp posterior margin which is known as scleral spar. So now what happened? The ciliary body is attached to the scleral spar. Now, when ciliary body is attached to the scleral pulp, let's see what happens. You can see the iris, how the iris is placed here. So here is the where the iris is joining there, that is called the iris root, and the part of the ciliary between the root of the iris and the scleral spar is known as ciliary band. Clear? So with this, we'll proceed. So you can see that when the trabecular meshwork, which get attached to the insert into the periphery of the cornea, then that creates a prominent ridge called Schwalbe's line. So this is how the Schwalbe's line is created. You can see here. Yeah. So here the Schwalbe's lines are actually formed. So now these are the structure. When we do gonioscopy, we see, for example, if you see here, we see like this. So you can actually use the mnemonic I can see till Schwalbe's line. So with that, you can see the iris root, ciliary body band, scleral spar, trabecular meshwork, and Schwalbe's line. So it requires lot of practice when you do gonioscopy. Otherwise, all the structures looks like this. So you have to identify. So try to do gonioscopy with this anatomic landmark in your mind. So now coming to the next blood ocular barrier. So there are two types of blood ocular barrier. One is blood aqueous barrier. So what is blood aqueous barrier? The blood aqueous barrier is composed of tight junction of the ciliary process of non-pigmented epithelium, the endothelial cells in the iris vasculature, and the inner wall endothelium of the Schlemm's canal. Whereas blood retinal barrier regulates the fluid and molecular movement, and it is actually caused by the inner blood retinal barrier and the outer blood retinal barrier. So inner blood retinal barrier is caused by the tight junction of the retinal capillary epithelial cells, and the outer junction is caused by the tight junction between the retinal pigment epithelial cells. So now next comes C for collagen. Okay. So now if you see, this is a very important structure. Any one of you tell me what is the most common collagen present in the eye? Anyone? So collagen 1 is the most common. So if you see that these are the structures of the collagens, and if there is any problem in this metabolism or in the structural integrity of the collagen, then we have the following disorder. For example, the collagen 1 is defective, then we can have osteogenesis imperfecta and Ehlers-Danlos syndrome, and you know that osteogenesis imperfecta, the sclera becomes thin and becomes bluish. So this is how it works. Now coming to the next important structure is the Descemet's membrane. Excuse me, can you switch off this light? It's this. So Descemet's membrane. So as you know, the Descemet cornea is bounded by two cellular layer. One is epithelium and endothelium, and each layer rests on a basement membrane, the epithelial basement membrane, and the Descemet's membrane. Now, having said that, if you see that wherever there is a swelling in the corneal stroma, so what happens? The cornea, the entire curvature of the cornea remains fixed, whereas the more elastic Descemet's membrane is displaced posteriorly, reflecting the changes in the shape. So that's how the DM folds are created. In cataract surgery, DM folds are created. So now the Descemet's membrane can break due to the corneal stretching. As you know, during the Descemet's membrane rupture, what happens during the forceps delivery, and the elevated IOP in infantile glaucoma stretches the cornea and causes the break in the Descemet's membrane. Now, this is a very interesting diagram. Actually, all of you should know that in Descemet's strip link endothelial keratoplasty, the layers actually involved are posterior stroma, Descemet's membrane, and endothelial. So you can take the picture, and madam is there, Dr. Shefali. She can also highlight that because it's her domain. So next we'll move to epithelial lining of the inner eye. So what are the epithelium that lines the inner eye? That is very interesting. You have to remember that what happens, the anterior pigment epithelium of the iris, it goes, and in posteriorly it becomes outer pigment epithelium of the ciliary body, and which further continues as a retinal pigment epithelium. Clear? So similarly, what happens, the posterior pigment epithelium of the iris, they lose pigments, and when they go to ciliary body, they become inner non-pigmented epithelium. Here you have to remember the same epithelium which is so much pigmented in the iris, they lose the pigment completely and become inner non-pigmented epithelium of ciliary body, and that actually continues as a sensory retina. So next, let's go to the fovea. So fovea, as you know, the most sensitive part of our eye, which is responsible for vision. So what we see here, you will see the normally in fovea, the fovea is a small central pit in the retina. And why this pit is formed? Because the retinal neurons are displaced, leaving only the photoreceptors in the center. So the arrangement of fovea is very important. You have to remember when you are reading your textbook, you have to remember that we have this pit formation because all the retina's neurons are actually displaced from the center, and that's how it is formed. Now, this area has highest density of the cones, and the ratio between cone cells and the ganglion cells approaches almost 1:1.8. Now, to achieve the outer segment of the cones, the fovea becomes elongated and extremely thin, looking more slender like rods. So unlike the conical shape of the in other part of that. So that's why you will see here the photoreceptor axons are become longer there, which deviate away from the center, and these are called actually Henle's fiber. So these are the basically Henle's fiber what you are seeing here, and you have to oblique course to because they are displaced here, so that's why they have to take their oblique course here. Now coming to the glands of the ocular G for glands. So can you tell me what is the secretory material by the goblet cells? Any one of you? And can you name any accessory lacrimal glands? I think you have. Okay, so, the goblet cells actually secrete the mucins, and the accessory glands are the Krauss and the Wolfring. So these are the secretory various glands we have in our eyes, the moles and gents. And look at, you have to remember the mechanism of the secretion also, like which gland is holocrine, which gland is exocrine. So this is a very important, and what the nature of the secretion. For example, goblet secretes the mucin and primary responsible for the secretion of the mucin, whereas the aqueous part comes from the lacrimal gland and the accessory gland, and the oil part of the tear film comes from the mainly the holocrine glands situated in the lid and the hair follicles. Now this is H for Hallers layer. So Hallers layer, as you know, that the choroid consists of three structures: choriocapillaries, Sattler's layer, and Hallers layer. So Hallers layer is a large diameter arteries. Like if you see, these are the large arteries will be there. Now this is very important observation in pathological conditions, that a state of focal and diffuse increase in the choroidal thickness accounted by the dilated choroidal vessels in the are called, these are called basically Pachy vessels, and a clinical spectrum have been identified, which is called actually pachychoroid. So pachychoroid is a state of focal or diffuse increase in the choroidal thickness accounted by the dilated choroidal vessels. So next, our structure is internal limiting membrane, I for internal limiting membrane. So you have to understand that the internal limiting membrane thickens to become more rigid with age. So by the age of the 83, the thickness is 20 times compared to the fetal membrane, fetal internal membrane, and also 37 times in the posterior pole, but very thin at the fovea. So this is how the internal limiting membrane acts, and it's a very tough material, and sometimes it's not that easy, and it contributes at least 50% of the rigidity of the retina. Now there are various dyes are there which are used for the staining of the internal limiting membrane while doing the surgery. So like the indocyanine green we have, and then we have a trypan blue, we have a brilliant blue. So you have to remember all this dye. Now J for the junctions. So let's go to the cell junctions. There are basically, you know, in 5 junctions in our body or in cellular structure. One is jonula occludens and the jonula adherens, and macula adherens, gap junctions, and hemidesmosomes. So I'll just highlight that hemidesmosomes, it's not a cell to cell junctions, but it's a cell and basement membrane junction. So abnormalities in the hemidesmosomes formation and junctions along with a focal, no, it can be seen in various conditions in diabetics and mainly in the recurrent corneal erosion syndrome. So next structure is a little different, because most of you don't pay attention when you read the anatomy of optic nerve. So that is called ocular structures of the cone. Now what is that? What is ocular structure of cone? This is basically the astrocytes and Muller cells provide support to the nerve fibers and blood vessels in ONH, and that's what, if you see here, that this is called central meniscus of cone. What is this? This is the central portion of the membrane. Which membrane? The membrane of Elsnick. So this you have to keep in mind. This membrane is called membrane of Elsnick. This membrane is called Elsnick. So membrane of Elsnick separates the optic nerve head from the vitreous and is continuous with the internal limiting membrane of the retina. Now the central part of over the optic disc, this is, we are showing a cut section through the optic disc, graphical representation. So this basically is a central meniscus of the cone. So similarly, there are several structures, like here, if you see the choroidal side, here choroidal side. So these are called intermediary tissues of the cone. This separates from the optic nerve from the retina, and when it comes to choroid, it calls a border tissue of Jacobi. So all these structures, usually you don't pay attention when you read the optic nerve anatomy. So you have to remember those anatomical structures, and you should know as a postgraduate. Now coming to this, the L for limbus, I won't go into the details. Already you have read a lot of this thing. So only thing you have to know that the warps of the palisade is at the radial projections, like you see here, and you have to remember about this this hypothesis where Thoft and Friend actually proposed this hypothesis, where the central epithelial epithelial maintenance. So where the X component actually denotes the basal cell proliferation, Y component shows the migration of the cells from the periphery to central cornea, and Z component denotes the loss of the cells from the surface. Now this is a German German ophthalmologist or anatomist, so Hendrik Muller. So what are the structures you know by his name? Anyone? Muller cells is one. So let me go take you to another peculiar structure called Muller muscles. Now, how many Muller muscles are there? Number one, superior tarsal muscles, like smooth muscles. You all of you know that originates on the posterior infra aspect of the levator muscles. The second one is the circular fibers of the ciliary muscles. So ciliary muscles, what are the ciliary muscles? The circular fibers are known as actually Muller's muscle. So now what are the other parts of the ciliary muscles? That's the middle oblique and the outer longitudinal part. So you have to remember all the part of the ciliary muscles, and the circular fibers are called Muller's muscle. So we got two Muller's muscle. Another third Muller muscle is there, which I think many of the oculoplasty surgeon also don't pay attention, but it's very important. So this is basically the orbitalis muscles in the vestigial stage. Basically, in normal adult, there is no such muscles, but it has a embryological significance. So this is called orbital muscle of the Muller. So now the N for neuroectoderm. So this neuroectoderm, if you see, you have to remember the embryologic development of the eye. Now, what are the structures that they derived from the neuroectoderm? So you have to remember the mnemonic MORE. M for muscles of iris, O for optic disc, R for retina, and E for epithelium of the inner eye. Already I showed in slide that what are the epithelium for the inner eye. Now the next structure is the mesoderm. So you have to remember eye and surrounding structure arise solely from the ectoderm and mesoderm, and there is no endoderm derived tissue. Correct. So now coming to the mesoderm, what are the structures are there? We'll come into there. Ectoderm, you have to remember there are secondary vitreous and primary tertiary vitreous, which is derived from the ectoderm. Don't take the photo now. Let me finish and then take the photo, then it will be useful for you. So mesoderm. So mesoderm you have to remember with MES. So M stands for muscles of the extraocular muscles, orbicularis oculi, levator palpebrae superioris, and endothelium of all eye orbital vessels, and so sclera, mainly the temporal with the scleral canal. So this is how it is. So neural crest, rest of the structures are derived from that. So you can take this photograph. So this defines the ocular structure derived from the ectoderm and mesoderm. And as I said that the endoderm solely from the ectoderm and mesoderm, and there is no endoderm derived tissue in eye. So this is as a whole the embryological development of eye. So now we'll go to the ora serrata. Because of the constant of time, we'll just keep those things. Only thing I want to highlight here, you have to remember this diagram very carefully, that what is ora serrata, what is equator, and how we define. These are very loosely defined terms when we tell retinal periphery, retinal mid periphery, and far periphery. But that is not important. The most important is this chart. What is the name of this chart? This is Amsler-Dubois chart. So Amsler chart, popularly known as Amsler chart. Now you have to know what are the different landmark in this chart. For example, the ora serrata represents the second inner the middle line. Remember, ora serrata doesn't mean the outer line, and the equator represents the inner circle. So this is very important to know. And even if I know one of our students was very brilliant and he could not answer this question at the end of his viva, and he failed finally. So I always, after that, I make sure that I show this slide to everyone and tell them that you have to remember this landmark, what are these circles actually signifies. So don't do a mistake, always pay attention and remember the circles here. Now coming to the P, palpable conjunctiva, but what we'll do, we'll just show you in one important slide. We want to, so this is about the circulation here. You can see the posterior conjunctival arteries and the anterior ciliary arteries, which occupies the muscular muscles, and this is how the conjunctival congestion and ciliary congestion actually varies. So conjunctival congestion is at fornices and towards the cornea, and conjunctival cornices occurs because of the palpable arcadae, and the posterior conjunctival arteries are involved, whereas the circumcorneal or the ciliary congestion occurs due to anterior ciliary artery and because of the anterior conjunctival artery. So this is the quiz time. I'll ask one a simple question, because Q, I could not find any anatomical structure with Q. So can any one of you tell me that what is the literal meaning of cul-de-sac? Anyone? Yes? Huh? Bag. No, cul-de-sac is not bag. It's called a blind lane. You have gone, no, you when you go to a street and suddenly after walking some, you feel that it's a closed. There is dead end. So that is basically the cul-de-sac. The conjunctival cul-de-sac when you mean no, the same like that. So retinal pigment epithelium again, I'll just give you that this thing. It's very important that what happens. These are the function you have to in exam you have to tell. So you can actually remember that with the RPE fit. You better you take the photo because I have to rush through my slides. Taken. Okay, I'll go to the next slide. So this is very important. You have to remember that what happens in this. If you see that there will be phagocytosis of the photoreceptor outer segments. So when there is a phagocytosis of the outer segment here, it will reach the RPE here, and it will accumulate as a lysosome. So these lysosomes, they will actually engulf them, and these will be taken actually washed away by the your choriocapillaries. So choriocapillaries will drain them. So this is how the lipofuscin starts actually accumulating in the retina, and this is how this comes. When we do autofluorescence, what we see some fluorophores, that because they get deposited in that, and that's how we this fluorophores. You have to remember the names of the fluorophores. These are lipofuscin, melanin, A2A, and oxidized flavoproteins. So there is again, you know that there is a suprachoroidal space, but always we have a misconception because we feel that it's a potential space. But experimental study, anatomical study, they have found that there is no such space basically, but a potential gap which can accommodate when there is a extra fluid and extra when we inject the drug. So what has happened? So this has been used as a for various, for example, various drug delivery has been tried. So what are the drug we have tried? It's triamcinolone acetonide, bevacizumab. A lot of drugs are new coming, exitinib and all. They are under trial. And then this space have been utilized for the retinal prosthesis also. In glaucoma, various surgical devices are coming which utilizes this space. And obviously the gene therapy, they have targeted this space for better delivery of the drug inside the eye. So trabecular meshwork, again, all of you know, I won't go into that details of that. And uveal tract, no, better if you want the anatomy lecture, you can go to the your this iFocus online and to watch my video which is entirely on anatomy and physiology of uveal tract. And then coming to the vortex vein. So vortex vein, what happens? Vortex vein drains the blood from the choriocapillaries and it coalesces into the collecting channel ampulla. As you know, the vortex vein ampullas are there and they exit the eye as a vortex vein and drain into the superior and inferior ophthalmic vein. So each eye has 4 to 5 vortex vein. And what is the significance of this vortex vein? You see this choroidal detachment here. Can you see the quadrilobular lobed appearance of this choroidal detachment? This happens because of the vortex veins in there. They don't allow the choroidal detachment to progress to the posterior pole. So Whitnell's ligament, again, I won't go into the details. It's basically all theory purpose. X, Y, Z. I'll take Dr. Shefali. I'll take 5 more minutes and I will wrap it up. So the Latin. So X actually, when I was planning this year, I had a lot of difficulty that how to put one ocular structure for that. So then I took help of this Latin term. So in Latin term, the Greek crossing actually caused the shape of the letter G or X. So that's why I have taken that optic chiasma for X. Now, optic chiasma, as you know, the decussation of the nasal retinal fiber to the optic nerve, which continues posteriorly, and then from retina, optic nerve actually takes it, and all of you already read. Now, I want to ask you a very interesting quiz question. That do you know which physicist first predicted that decussation of the fiber in our brain? Anyone? One person who first actually thought that there will be decussation of the fiber. That's how we can see. So he was none other than the Isaac Newton. So Isaac Newton first gave the idea that decussation of the fiber happens. So how powerful it is. One physicist who had no idea about ocular anatomy, he predicted just only on the basic of his physics knowledge that there will be decussation of the sum of the optic fiber. That's why our visual field is like that. So now coming to the AIOC muscle, so why we called this separate this extraocular muscles and subdivide them into spatial group. So the name comes from the AIOC. I think you have seen in agriculture field that AIOC is a wooden bar that is fastened over the neck of the two animals, especially the cattle, and so that they move together. So similarly, our ocular muscles also, they move together. Like if you see this sets of, these are called AIOC muscles. Just like this cattle, no, they also move together and uh, helps in our this function. So now coming to this Z. So can you name some vascular circle or arterial circle related to the eye with Z? Huh? Circle of? Correct. And so there are many circles you have to remember, not only Z. Can you name other arterial circles? What are the arterial circles we have? Not anywhere. In entire eye, how many? There are actually 5 circles. One is the major arterial circles in the iris, then the minor arterial circles, then the circle of the Jean and Heller, and episcleral arterial circle formed by the anastomosis of the adjacent anterior ciliary artery, if you see, and the intramuscular arterial circle. So here it's all about the circle of the Jean and Heller. So the circle of Jean and Heller is formed by the 10 to 20 short posterior ciliary arteries which enter the sclera to form the anastomotic ring around the optic nerve, and this supplies the anterior part of the optic nerve and posterior choroid. As you see there, here is the circle of Jean and Heller, and you can see that how 10 short posterior ciliary artery and this posterior ciliary artery forms it. So can you name some other structure named after this Jean? I think we are just last slide. So, something related to when you do cataract surgery. If that structure is not there, then you may have to put CTR of zonules of Jean. Okay. So then any other? Annular subgene. Okay. Now just before I conclude, now can you connect this flower with this ocular structure? What is the name of this flower? Huh? No, this basically actually this gentleman, the name of the gentleman is Jonathan Zinn. He was a botanist and anatomist from 17th century, both botanist and anatomist, and this is the flower zinnia which is named after him. So zinnia, if you next time you see a zinnia flower,